Very good evening, everybody. Good evening, good morning. हाँ बच्चों, all well? Okay. So as promised by Dr. Deepthi, I have now starting 5 minutes late, so that everybody. Okay. Everybody is having at the right phase of mind, and so let's start with today's class and what is my plan for today. Okay. So my plan for today is this. Okay. So far in my class, I have mainly talked about pulmonary part of the chest X-ray. Okay. Today I will talk about cardiac part of the chest X-ray. Okay. Which is not a big topic. It's actually a small topic. If you allow me, I will be able to finish it at a good pace. There's not much to be done, but whatever I will tell you will be all that you need to know about a cardiac part of chest X-ray, and that is all we need to do in the first half of the day. In the second part, I want to start with bone tumors. Okay. That is my intention for the day. Okay, we are done with the pulmonary part. I will start with the cardiac chest X-ray, and then I will go on with the bone tumor. Okay, everybody understands? Okay, but I'll try my best to remain fast, and I'll try to finish as per the schedules. Okay, everybody okay with it? Okay, I can see your suggestions are coming in. Okay, now everybody now. So let's quickly revise where we were in the last class. In the last class, towards the end, we were looking at the CT anatomy of the thorax. Specifically speaking, we were looking at CT anatomy of the mediastinum. Okay, we were looking at CT anatomy of the mediastinum. I will quickly run through the structures just to make sure that those of you who were not able to see in the last class will be able to revise. I am better relax. I'm going at a decent pace. Don't worry. Okay. I will not go fast, not go slow. Don't worry. I'll go at the correct pace. Okay. You have to trust the teacher. Okay. I know the correct pace that is required, beta. This is your right brachiocephalic vein. We saw the superior mediastinum. This is the left brachiocephalic vein. This is the brachiocephalic artery. Left common carotid artery, left subclavian artery, trachea, esophagus. Okay, so I'm sure most of you are able to recall the anatomy of the superior mediastinum. I think we've spent a lot of time on this in the last class. Then I had shown you, beta, if you remember, the arch of aorta, and we saw the superior vena cava, and we saw the area called as anterior mediastinum. Okay, or the prevascular space in front of the aorta, that is where you have the thymus. Okay, this is what we discussed so far. LC is the left common carotid artery, with a left common carotid artery. Then if you recall from my last class, okay, I'm just revising from the previous class, beta. Okay, in the last class I told you that the structure which is anterior is the ascending aorta. Posteriorly you have the descending aorta. I told you that this is your superior vena cava, and this is the azygous vein draining into the superior vena cava. We also saw trachea, and behind the trachea we saw esophagus. Are you able to recall all this? Yes. Some people are asking how much done. Better nothing done, only last class we are looking at. Okay, and we saw this is the left pulmonary artery. So we're just revising the last class because I know some of you will be joining late after having good food by your mummy has made. You must be now having those food and coming back. So we can see the ascending aorta is anterior, descending aorta is posterior, and we saw along with the ascending aorta you have the superior vena cava, and we saw trachea, behind the trachea esophagus. Okay, then if you recall, in the next section I taught you ascending aorta is anterior, descending aorta is the one which is sitting with the vertebra, main pulmonary artery is shaped like a reverse Y, right and left branches, superior vena cava. Everybody clear? Everybody clear? Okay. Now tell me if you are able to remember, this is your ascending aorta, descending aorta, main pulmonary artery, right branch, superior vena cava. So it is very simple to understand. Ascending aorta is the one which is anteriorly placed. Descending aorta is the one which is right next to the vertebra. Okay, then we are able to always understand it clearly. Everybody? Yes, clear. Now let's see if you can answer better. Then this was the difficult part. Descending aorta, aortic root, right ventricular outflow tract. So the dilated part at the bottom that we see of when we were tracing the ascending aorta, now we see a dilated part, that is the aortic root. This aortic root is the part where you have sinus of Valsalva, and in the sinus of Valsalva you can see the coronary artery coming out. This is your left main coronary artery. This is your left main coronary artery that I'm drawing here. And I also told you that this is where some of you were saying, "Bas sir, khatam kar do." Nahi, maine kaha nahi padhenge. This is your superior vena cava, and from the junction of the superior vena cava and the right atrium, there is a tubular outpouching coming out like this. This is called as the right auricle. Do you remember from your anatomy class that atria have a tubular outpouching called as auricle, and the right auricle is present just anterior to the aortic root. Okay, this was your right auricle. And then I told you that these are your superior pulmonary veins. And I told you where the superior pulmonary vein is joining the left atrium, you have a tubular outpouching which is more broad in shape, which is called as left auricle. Okay, and you might now understand that you were okay. We have not started, we are just revising the previous class till the time everybody joins in. So you remember or not that in anatomy they told you कि जो left auricle होता है वो ज़्यादा broad होता है. Left auricle is more broad than the right, and that is why you might see in patients with mitral stenosis, sometimes in atrial fibrillation, you might see a thrombus in this area. So this is your left auricle. Okay. And then I told you to identify that now if we trace the superior vena cava, it has actually gone into the right atrium. This entire thing is your right atrium. Okay, so right atrium is towards the right, but the posterior most cardiac chamber is the left atrium. This must be your inferior pulmonary veins opening into it. This is descending aorta. In the center, you have your aortic root, right ventricular outflow tract, and in the final image I taught you that right next to the vertebra is the descending aorta, anterior most cardiac chamber is the right ventricle, posterior most cardiac chamber is the left atrium, the cardiac chamber which has the thickest walls is the left ventricle towards the right atrium. This is how we always label the this is how you label the cardiac chambers. सबसे आगे right ventricle, सबसे पीछे left atrium. So this is the key to understand, and the thickest wall is with the left ventricle, so that makes it easy to understand that आगे की तरफ right ventricle है, जिसकी wall मोटी है वो left है, सबसे पीछे left atrium. Once you are able to do this, you will always be able to solve it. SVC is bright in this image because we have given IV dye. Can you imagine now if I give intravenous dye in the antecubital vein, it will go into the axillary vein, right brachiocephalic and the superior vena cava. So we are actually giving intravenous dye in this patient. So disproportionately you see a little bit more dye in the superior vena cava than the other structures. Everybody clear? Okay. So this is where sinus of Valsalva beta वो थे ना जहां से coronary artery arise करती है. Remember, Divya? So sinus of Valsalva are those structure from which the coronary arteries arise. So they are present in the aortic root. If you try to see, although this is a routine CT, still you can see a small structure arising from the aortic root. This is your coronary artery. This is your left main coronary artery. If you remember, from the left main coronary artery, a branch goes anteriorly and below, that is the anterior descending, and a branch goes around the heart, which is the circumflex. Do you remember the branches of your coronary artery? Yes, very good. So this is where we were in the previous class. Okay. Now we come to today's class. The goal of today's class, in the first half, I want to cover how we see cardiac diseases, both adult and pediatric cardiac diseases, on a chest x-ray. Okay, this is my goal for today. So everybody now wake up. We are now finally starting the class. Okay, I'm so sorry if I shouted, but that's okay. I just wanted to wake you up, bache. Subah hai beta, it's just morning, beta, get up. Okay, so in cardiac imaging, my goal is this. Good morning. Yes. My goal is, first of all, I want you to understand how to identify left ventricular failure or CHF on X-ray. Okay. Okay. Everybody, we're just starting, beta. So, beta, here I see always, you always come and ask how much done. We nothing done, beta. We just started. Okay. So, first topic of the day is left ventricular failure. Okay. Left ventricular failure. Okay. Beta, see with me. Now, how do you identify left ventricular failure on X-ray? If you have left ventricular failure, it leads to increased PCWP. Is this much small concept clear to you or not? If you have left ventricular failure, it leads to increase in pulmonary capillary wedge pressure. Okay. Now, so when the pulmonary capillaries have high hydrostatic pressure, they start leaking. They start leaking fluid, and that is called as pulmonary edema. To be precise, we will call it cardiogenic pulmonary edema. So I am sure you are now clear that in chest X-ray, okay, in chest X-ray, in heart failure, what will we see? We will see cardiogenic pulmonary edema due to increase in pulmonary capillary wedge pressure. So what will we see on the X-ray? If you get the concept, better listen to me. If you understand the concept, the X-ray finding will become easy. Otherwise, you will have to mug it up. So what we'll do, we'll try to go in the concept manner. Better see with me. Suppose if I draw a cross section of the lung, okay, if I draw a cross section of the lung, PCWP matlab pulmonary capillary wedge pressure. Okay, you might have read about this in your Genong in first year, but you might not have read in the first year. I caught you. Don't worry. PCWP matlab pulmonary capillary wedge pressure. Starling forces सिखाया था ना first year में. Okay. So now see, I'll explain to you. Don't worry. So suppose these are your alveoli. In between, you have the connective tissue of the lung, which I'm labeling as interstitium. Lung में connective tissue को कहते हैं interstitium. In the interstitium, you have pulmonary capillaries. In the interstitium, you have pulmonary capillaries. Okay. Can anybody tell me what is happening between the capillaries and the alveoli? Can anybody tell me what is happening between the capillaries and the alveoli? Blood gas exchange is happening. Oxygen is going into the blood and carbon dioxide is going to the alveoli. Blood gas exchange is happening in this area. Okay. And notice now, in addition to this, in the interstitium, you always also have lymphatics. Interstitium में आपको lymphatics भी होंगे. Okay. Okay, let's see an answer, beta. Everybody now listen to me. Now focus on me. Okay, don't look at the chat box. Look at the screen here. Okay, look at the screen. Very important concept. If your PCWP is high, now tell me, if the pressure is high, what will happen to the capillaries? Anybody? क्या पढ़ा? Starling forces पढ़ी थी बेटा first year में. Starling forces. Anybody? If the capillary pressure is high, what will happen to the capillaries? The capillaries, they start to leak fluid. But it is difficult concept, but listen to me, okay? Do you agree, all of you, that Starling forces say that if there is increased pulmonary capillary wedge pressure, okay, you will have the Starling forces acting on it and the capillaries will start leaking fluid, okay? So when the capillaries start oozing the transudative fluid around them, can you now understand where will be the fluid seen first? Fluid will be first seen around the capillaries. So you will first have pericapillary ooze. Do you agree? Now, any one of you can now think and answer, beta. It is very difficult. I want you to focus, otherwise you will get it wrong, beta. Sunenge mere saath. If now between the capillary and the alveoli, if between the capillary and the alveoli you have fluid layer because of pericapillary ooze, what will happen? What will happen? Blood gas exchange will not be happening. Do you agree? Because of edema around, the fluid leaking around the capillaries, the blood gas exchange will not happen. If the blood gas exchange does not happen, the capillaries the blood in the lung starts to develop hypoxia. Do you agree? Okay, starts to develop hypoxia. Are you clear with this or not? Yes, beta, listen to me. Otherwise, you will keep mugging up for me. When you become resident also, first year PG also, you will be mugging up. Try and understand. If you have hypoxia, what will happen to the pulmonary vessels? What will happen to the pulmonary arterioles? Anybody? If you have hypoxia in the lung, what will happen to the pulmonary arterioles? Okay. The pulmonary arterioles undergo vasoconstriction. Are you clear? In response to the hypoxia, pulmonary arterioles undergo vasoconstriction. Are you clear with this or not? Okay. This is different from systemic vessels. In systemic vessels, you have vasodilatation if there is hypoxia. In pulmonary vessels, if there is hypoxia, there is vasoconstriction. Very good, but I can see many of you are able to answer. Now listen to me. Now the problem in the lungs is, in lungs, okay, the problem in the lungs is, in lungs, PCWP is highest in the lung base. Okay. In a normal person also, capillary pressure is highest in the lung base. Now tell me, are you able to understand that in heart failure, because of the pericapillary ooze, which is predominantly seen in the lower lobe, it is the lower lobe blood vessels which will undergo vasoconstriction. It is predominantly the lower lobe blood vessels which will undergo vasoconstriction. Now imagine, suppose these are your lungs. Okay, suppose these are your lungs. Now what happens is, it is difficult to understand, but try and understand. The right heart is pumping the blood. Left heart fail hua hai, right heart abhi blood pump kar raha hai. So from the right ventricle, the blood is going into the pulmonary arteries. But what is happening is lower lobe arterioles are constricted because of the hypoxic environment. They are constricted. So blood is selectively going into the upper lobe. Now, when you look at the X-ray, you start seeing that the upper lobe vessels appear more dilated than the lower lobe vessels because the lower lobes have gotten constricted. This is called as cephalization of blood flow. Everybody understands? You might have seen this question multiple times. What is the first chest X-ray change of heart failure? The answer is cephalization of blood flow. Okay, because of the gravity, the lungs are arranged in this manner that now. So this is where the MCQs are. Now many children are just mugging it up, but if you mug up, then there is no joy. You will be frustrated that what am I doing? This is the first chest X-ray change of heart failure. The upper lobe vessels appear dilated more than the lower lobe, which is different from normal person. In a normal person, the lower lobe vessel should be more dilated than the upper lobe, but in heart failure, it changes. That is called as cephalization of blood flow. So do you understand now? The problem is, beta, see, try and understand, beta. This is a fact, okay, and this is the concept. Okay, the problem here is in the exam, they will ask you the fact that what happens on X-ray in heart failure. But if you don't know the concept, you will not be able to recall, you will keep mugging up and it will not sound good to you. You will not enjoy it. Okay, so that is where the concepts are more entertaining. They make your brain feel good about things. Okay, so this is how the heart failure begins. Now what happens? Now what happens is, try and understand with me. Now the fluid from the capillaries starts to ooze into the interstitium. Now that fluid which is leaking from the capillaries because of heart failure will go into the interstitium. Now anybody of you can answer. We are looking at the first page, beta. Okay, anybody can answer, beta. If you have fluid in the interstitium, can you name a structure which we have drawn, which will drink and clear all this fluid? That structure is lymphatics. Do you agree now? Now what will happen is, everybody see with me. Now what will happen is, after cephalization, what will happen is, you will start to develop interstitial edema. And in interstitial edema, what happens? You start developing lymphatic engorgement. In the interstitial space, you have the lymphatic channels, and the lymphatic channels become dilated. Okay, everybody understood? Now I'll tell you a concept again, and this concept you will, once you understand, you will be like, wow, eureka, because you know all this, but you really don't know it. Okay, trust me, listen to me. Okay, now what will happen is, if these are your lungs, everybody focus on it, beta. All the chota bachas, please focus. Okay, I'm trying to act like Deepthi a little bit. Okay, now please see with me. If this is your lung, okay, in your lung, these are your lymphatic channels. Okay, so lymphatic channels in the lung are starting at the pleural surface, are starting at the periphery, and they are converging onto the hilum, converging onto the center. And suppose if this is your horizontal fissure, again at the fissure also, at the pleural surface, you have lymphatics converging towards the hilum. Okay, everybody clear? Let's see if you can answer, beta. Everybody focus and answer, beta. Focus. Now, in the lower lobe of the lung, the capillaries were leaking because of increase in PCWP in heart failure. And the capillaries which were leaking, the fluid will go into the interstitium and it will go into the lymphatics. So now your lower lobe lymphatic channels will become dilated. Okay. Now what will happen is, starting at the pleura, you will see horizontal lines at the lung base because of the lymphatic engorgement, the peripheral lymphatic engorgement in the lower lobe. These are called as, Dr. Curley described them, so we call them curly B lines. Everybody clear? Are you clear with this or not? Okay. So now do you understand what is curly B lines? Curly B lines are finding that you see in heart failure because of interstitial edema, because of lymphatic engorgement. These are horizontal lines starting at the pleura, seen at the lung base. Everybody understands? Very good. Okay, described by Dr. Curley. Okay. Okay. Now let's see if you can answer. Later on, what will happen? Later on, even the central lymphatics might become dilated. So when the central lymphatics become dilated, they are seen as lines radiating from the hilum. They are seen as lines radiating from the hilum. We will call them curly A lines. Okay. Now anybody, let's see. Now do you understand that you were thinking that you know, but you were getting confused? Let's see if you can answer, beta. Okay. पहले कर्ली बी दिखेगी कि ए? पहले कर्ली बी आएगी, फिर कर्ली ए आएगी. कर्ली नहीं है, लाइन सीधी है. आदमी का नाम है कर्ली. Okay, Curly was a British doctor pulmonologist to describe them. His name was Sir Peter Curley. So this is Curly lines. Okay, so these lines on the X-ray, they start at the periphery, so they touch the periphery, so we say start at the pleura, beta. Okay, now any one of you can guess an answer, beta. Let's see a concept, beta. Concept. Even your fissure is a pleural surface. So the lymphatics around the pleural surface in heart failure can get dilated and it can become fluid filled. Okay. So in heart failure, this fissural engorgement, the fissure becomes thickened and dilated. What do you call it? This concept is called as phantom tumor. Everybody clear? Have you ever heard of this before? Phantom tumor. Okay, is that understanding clear? So in the exam they will say phantom tumor seen in. Phantom tumor is seen in heart failure. Okay, it is engorgement of the fissural lymphatics that is called as heart failure. Okay, very good. Now let's see if you can answer. Now what will happen is, okay, everybody understand, okay, focus on me. Now the water from the interstitium will start overflowing into the alveoli. Water from the interstitium will start overflowing into the alveoli. Okay, everybody understands? Now what will happen is, when in the lungs, okay, when in the lungs the alveoli become filled up with fluid, they will become white. Do you understand? Alveoli should have air. Now the alveoli have edema. So because of alveolar edema in the lower lobe, predominantly in the central part, you will develop opacification. So the alveoli in the lower lobe, predominantly in the central part, become opaque. What is this? This is alveolar edema stage. This is called as bat wing appearance. This is what is called as bat wing appearance. And along with that, the pulmonary capillaries also start to ooze. When the pleural capillary starts to ooze fluid, you also develop pleural effusion in heart failure. Okay, so you also develop pleural effusions in heart failure. Everybody clear? Everybody understands? Okay. Why not upper lobe? Because in the lungs you have a gradient. PCWP is highest at the lower lobes. So in heart failure, the edema predominantly manifests in the lower lobe, and that is why you have this curly B lines also in the lung base. Bat wing appearance is also in the lower zone central part. Everybody understands? Okay, yes, very good. So I can see now, you know, we have made a concept. I will teach you how to look at an X-ray also, but we have made a concept that, okay, how to identify heart failure on X-ray. Because as an MBBS doctor, if you don't know how to see heart failure, you will not feel good about yourself. Okay, my question to you is this, beta. Everybody listen to me, beta. Everybody. Have you ever heard of ARDS? What is ARDS? Non-cardiac pulmonary edema. If there is a disease process like pancreatitis or like COVID pneumonia, you might have heard of this before, that coronavirus is causing an immune response. So what happens is, if there is a systemic disease causing an inflammatory response, what will happen to the pulmonary capillaries? The pulmonary capillaries will become leaky. Do you understand the basic principle that I taught you in the first class, second class? Inflammation में capillary leak करेगी, तो यहाँ capillary leak हो जाएगी. Okay. What about the PCWP? PCWP तो normal है. Okay. Are you clear with this or not? Are you clear? Are you able to answer this or not? That in systemic inflammatory diseases, you may have increased capillary permeability leading to ARDS, which is non-cardiac pulmonary edema. In this, PCWP will be normal. Okay, let's see if you can answer. बेटा सोच के बताना है। ARDS में लंग में इडीमा PCWP के कारण है कि कैपिलरी परमेबिलिटी के कारण है? बोलो। In ARDS, edema is because of increased capillary permeability, not because of PCWP. Now, inflammation में क्या upper lobe, lower lobe gradient होगा? We have a systemic inflammatory disorder happening. Do you think it would have upper lobe, lower lobe gradient? No. Systemic inflammatory process would affect the entire lung. So, chest X-ray will show diffuse opacification of the lungs. Okay. And because this is alveolar opacification, it is the alveoli which are becoming opaque. If the alveoli become opaque, the X-ray shows air bronchogram, which I have already covered with you in the last class. So you will have lungs will be white with air bronchogram in ARDS. Usually there will be no cephalization in ARDS, no bat wing appearance in ARDS, no curly bee lines. And usually pleural effusion is also seen more in heart failure, not in ARDS. Okay. So now you will have a flashcard forming in front of you, and you will see the return of my flashcard technique happening in front of you. The technique is, this is the difference between a cardiac and a non-cardiac pulmonary edema. This is the difference between a cardiac and a non-cardiac pulmonary edema. How do you understand on a X-ray? Okay. How do you understand on a X-ray? Is this okay? Is this okay? Is this a cardiac edema or ARDS? Listen to me, beta. So in ARDS, the chest X-ray will have diffuse opacification of lungs. Air bronchogram will be seen. Because the disease process is alveolar, it will have air bronchogram. No cephalization, no bat wing appearance, no curly lines, no pleural effusion. Presence of all this is a pointer towards a cardiac origin of edema. Diffuse white lungs in a patient with pancreatitis, in a patient with COVID pneumonia, we'll think of ARDS. Everybody understands the concepts? Are you able to see the basic concept happening? So now, so some of you are finding it difficult. So I will just quickly give you a recap what I have told you so far. Only thing that we have seen so far is why the X-ray is different between cardiac versus non-cardiac pulmonary edema. भाई पल्मोनरी edema मतलब लंग में पानी भरना. लंग में पानी भरने के दो कारण हो सकते हैं, या तो कैपिलरी में प्रेशर ज्यादा हो जैसा हार्ट फेलियर में होता है, या कैपिलरी की परमेबिलिटी ज्यादा हो जैसी इन्फ्लेमेशन में होती है. You understand the difference? This basic difference people are unable to understand, and then they keep doing questions wrong. Okay, everybody clear with this or not? Now curly bee lines are seen in the heart. I will summarize everything with the X-rays again. I'll show you the films, but remember, okay, remember PCWP in ARDS is normal. PCWP in cardiac failure is high. Okay, that is the difference. And I also want you to understand that in heart failure, there is a basal predominance of X-ray findings because pulmonary capillary pressure is maximum in that area. That is why you see at the lung base curly bee lines, which are characteristic X-ray findings of, okay, which are characteristic X-ray findings of, remember, heart failure. Very good. Now we come back. Okay. Now let us summarize everything. Okay, let's summarize everything with the example. Let's look at some X-rays first. Okay, let's try and look at our X-ray here. Because the key is not to, okay, the key is not to, run, the key is to go slow and get to the idea. Okay, listen to me. But, okay, everybody try and understand. Suppose if this is your heart, okay, Do you see in this chest X-ray there are opacities? Can you see there are white fluffy opacities? X-ray chest, if I see something white, I call it opacities. These are fluffy, not very white, fluffy. Lower zone, central predominant. Can you give it a name? Yes, I can call it bat wing appearance, seen in left ventricular failure. Clear? So let's see and understand. So what I told so far is that please see that in this X-ray, the opacities are predominantly seen in the lower part, in the central part. That is why we are using a term bat wing. Do you know what is a bat? Bat is a flying mammal. Okay, you might have heard of a bat before. It is not a bird. It's not a bird, it's a mammal with wings like this. Okay, now why we are not calling it as bird wing? Why we are saying bat wing, beta? Okay, anybody understand why we are saying bat wing? बेटा बर्ड के विंग ऊपर होते हैं. ओके, बर्ड के विंग उसके पीठ पे ऊपर की तरफ होते हैं. बैट के विंग्स आर इन द लोअर पार्ट ऑफ द बॉडी. सो व्हेन द हार्ट फेलियर द फ्लूइड इज accumulating in the lower part of the lung. That is why we are saying bat wing. Okay, so keep it in mind, bat wing. Okay, and you know the value of bat today. एक बैट ने पूरी दुनिया को हिला दिया. Okay, with corona we never thought it would happen, but it is happening right now. So let's not take things for granted. Okay, let's just try and understand. I am saying a small thing or an animal like bat has capability to shut down the entire world. So that means small things have power. Now if I now tell you today that your small hard work that you put today has potential to help you create a massive medical career. True or false? You might not believe, but the answer is true. Small things are, listen to me, small things are very powerful. Don't underestimate the value of the small hard work that you do, small efforts that you do. Gradually they will all build up and you will have big things happening. You know, nobody thought a small animal like bat could have an impact like we see today. Similarly, you're working hard tonight, you know, you're giving me 5 minutes extra, are all going to contribute towards your career. Now let's see the next picture. In the next picture, I want you to focus on it and tell me, this machine that you see here, is cardiac pacemaker. Okay, so don't panic if you don't know this. This is how a cardiac pacemaker looks like. Can you see this is the battery and there is a lead going into the right heart. Okay, this is how a cardiac pacemaker looks like. Okay, now I want you to comment on the heart size. What do you think is the heart size of this patient? Definitely the cardiothoracic ratio is more than 0.5. Definitely the cardiothoracic ratio is more than 0.5. There is cardiomegaly. Okay, now if we have cardiomegaly, do you have any changes of pulmonary edema? Okay, do you have any changes of pulmonary edema? Let me zoom the lower part of the lung here. I'm zooming the lower part of the lung here. Okay, I want everybody to, you know, we have zoomed it a lot for the mobile screen. Let's see if you are able to see this here. Beta dekho, can you see here? In the lower part of the lung, if you pay attention, you will see such horizontal lines. Can I call them something? Yes, I will call them curly B lines. Now, can you put things together and tell me what has happened to this patient? He has a large heart with interstitial edema in the lungs, evident by curly B lines. That means he has heart failure. Everybody understands? Are you able to see this? Are you able to see the curly lines? Yes, very good. So this is in this page, if you notice, I've only talked about the first page. I've only talked about heart failure because I think that is very important to talk about. Okay. Now, the second concept that I wanted to make for you is again a conceptual thing, but it will help you a lot when you read pulmonology in medicine. Okay. Today, the smallest unit of the lung which is CT visible is. Okay. Now this is different from, okay, this is different from the, if you talk about the functional unit is different. Okay, well, physiological units will be different. What I'm saying is, lung में सबसे छोटी चीज क्या है जो CT scan पे दिखाई देगी. Okay. Now when I say CT here, I mean high resolution CT. Remember we talked about HRCT 1 to 2 mm thick slices wala. Okay. Now please see. The smallest unit of the lung which is visible on CT is called as secondary pulmonary lobule. Okay. Smallest unit of the lung which is CT visible is called as secondary pulmonary lobule. Now, how does it look like and why am I telling you this? Okay. It will take 5-10 minutes. Okay, it will take 5 minutes, but then a lot of your words that you will read in Harrison, everything will become clear. Listen to me. Secondary pulmonary lobule looks like a polygon. Secondary pulmonary lobule looks like a polygon. This is how it looks like. Okay, very good. It's a polygonal structure. Very intelligent students. In the center of this secondary pulmonary lobule, you have the bronchus. In the central part, you have the bronchus. Accompanying the bronchus, you have a branch of pulmonary artery. Okay. And in the septa between the two lobules, you have the veins and the lymphatics. Okay. So I'm again saying, okay, now try and understand this term here. Okay, listen to me. If I say a disease in the lung is centrilobular, मतलब क्या हुआ? बीमारी secondary lobule के center में. So we usually believe that this should be a bronchial origin disease. Disease must be originating from the bronchus. Let's imagine now. Do you remember in my last class, I told you TB can spread via the endobronchial route. Okay. अब बताओ, endobronchial tuberculosis on a CT scan will show opacities in the centrilobular region. So this is what is written in your medicine books. TB will show centrilobular nodules. यानी secondary lobule के center में दिखेगा nodule. Because the bronchus is central, that is the reason. Okay. Now, similar finding will also be seen in initial part of silicosis. शुरू में silicosis में भी ऐसा होगा. Can you tell me why? Because silica lung में कैसे आ रहा है बेटा बताओ. So you are inhaling, you are working in a sand mine, you are inhaling silica, it goes into the trachea, bronchus, and it goes into the lungs through the bronchus. So initially, in early stages of silicosis, you will see centrilobular lesions. Everybody understands? Very good. Now see, let's see if you can answer. If a disease is causing thickening of the septum, these are the septa. So if the disease is causing thickening of the septum, we believe that the disease is having a lymphatic origin. So if there is septal thickening on CT, we will call it septal lines, and we believe that the origin of the disease is now believed to be lymphatic. So what can happen in the lymphatic? Lymphatics can be engorged with fluid in a patient with heart failure. So this could be heart failure if you have septal thickening. Or lymphatics can be thickened because of a lymph node disease called as sarcoidosis. Or there can be a tumor spreading into the lymphatics of the lung, which is called as lymphangitis carcinomatosa. Okay. Now let's see an answer, beta. Everybody now. Septal lines are because of lymphatic engorgement, which we see in heart failure, sarcoidosis, and lymphangitis carcinomatosa. Now, can anybody tell me, CT scan, we saw septal lines because of lymphatic engorgement. What was seen on chest X-ray in the early part because of lymphatic engorgement? Curly lines. So I can actually say chest X-ray, if you find curly lines, so in that patient on a CT scan, you will find septal lines. They are equivalent. Their pathogenesis is same. So sometimes in your exams, they will say, and they will ask you this tough question, curly lines are found in heart failure, right or wrong? Correct. They will say, can you see them in sarcoid? Yes. Can you see them in lymphangitis carcinomatosa? Yes. Why? Because all of them are problem in the lung lymphatics. But if you don't know this, you will not be able to solve this AIMS level, PGI level question. Everybody understands the concept? Okay. The key word here was lymphatic. Once you understood the lymphatics, the game started to flow. Now see, if the distribution of the disease in the lung, if some of the nodules are central, some are septal or random. So if you see randomly distributed nodules in the lung, we believe that it should be a hematogenous process. क्यों? क्योंकि blood vessel तो center में भी है, periphery में भी है. So in the center we had the pulmonary artery, in the periphery we have the veins. So hematogenous processes will have randomly distributed nodules. Can you name some hematogenous diseases in the lung? Miliary tuberculosis, lung metastasis. Okay. Now tell me. Okay, let's listen to me and answer, beta. Silicosis में बेटा सोच के बताना. Silica entered the lung through the bronchus, through the trachea, inhalation. So initially we had centrilobular lesions. Then the silica was taken up by the macrophages, and macrophages will take it to the lymphatics. So that means silicosis will also have lymphatic engorgement, and it can also lead to septal lines, curly lines in the image. Do you understand now? In silicosis, the disease starts with endobronchial lesions. So it starts with centrilobular lesions and progresses on to septal lesions. So we'll have both the kind of findings in silicosis. Are you clear? Okay. Are we able to understand that if a disease has randomly distributed nodules, they are in some of the lobules, they are central, some they are peripheral, we will call it hematogenous process like miliary TB or metastasis. Now, conceptual question to you. Let's see how many of you can answer this conceptual question, beta. So this was how secondary pulmonary lobules look like. Can you name a disease of the macrophages? Okay. Can you name a disease which affects the lung macrophages? And because of this macrophages, it could be a primary disease, it could be secondary to some other disease, secondary to smoking, secondary to some other disease. This problem with macrophages leads to accumulation of surfactant in the lung. Okay. Because of this surfactant accumulation, the alveoli, all the alveoli become hazy. The alveoli become hazy. They become white, but not very white. They become hazy. So this haziness is called as, in CT scan, we call it as ground glass. Not only that, because the lymphatics will try to clear the surfactant which has accumulated, the lymphatics will also get engorged because of the lymphatics getting engorged because of the surfactant lipoprotein that they are trying to clear. So the lymphatics, the septa will also thicken. This is what is called as the crazy pavement appearance. If you have two findings, ground glass appearance with septal thickening, we will call it crazy pavement appearance. And I'm sure you have already identified the disease. I'm sure you are able to understand. This is called as alveolar proteinosis. But if in this year's NEET exam they give you crazy pavement, please remember it is also seen in COVID-19 pneumonia. Okay. So in between, I have been telling you some classic findings. Like earlier, if you say crazy pavement, I would always say alveolar proteinosis. Nowadays, if you say crazy pavement, I will say COVID-19. So now you know that if I recall, what are the X-ray findings that you will see in COVID-19? The most important finding is, remember, ground glass opacities, which are usually peripheral, rounded in shape, which can go on to develop consolidations, crazy pavement-like appearance, or it might develop organizing pneumonia leading to reverse halo sign. Okay, so these are the words that you will hear about. These are the words that you will hear about when they talk about COVID-19 pneumonia. So these are all the possible chest X-ray findings in COVID pneumonia. Ground glass for opacities, peripheral in distribution, round in shape, going on to consolidations, going on to crazy pavement or reverse halo appearance. Okay, so this is very important to remember. Now, once you're clear, but this is theory. My goal is to show you practical. Okay, so we'll go and see the image, how it looks like. Okay, we will see the image and try to diagnose it on the real image. Okay, so I want all of you to look at the screen in front of you. You will see a road that you will take to go back home late at night. Oh, you are already at home. Okay, so when maybe you might use this later on in this college. What is this? This is the actual crazy pavement. This is what is called as crazy pavement. Can you see the cobbled street made with stones? This is what is called as the crazy pavement. Brilliant. Okay, this is what is the real crazy pavement. Now I want you to see the CT scan with me. Do you agree that these areas in the lung, in this patient CT, they appear hazy, they appear ground glass, hazy, ground glass? Yes. But not only are they hazy, in between, if you appreciate, there are some thickened polygonal structures here. These are septal thickening. So ground glass appearance with septal thickening. What do you think? Ground glass appearance with septal thickening. What do you think? Crazy pavement appearance. Ground glass appearance. Okay. With in between, if you appreciate, you will see those polygon because of the thickening of the interlobular septa. This is called as crazy pavement appearance. Crazy pavement appearance on a CT scan is seen in alveolar proteinosis. Alveolar proteinosis, where you have a macrophage disease leading to accumulation of surfactant. But don't forget, the same finding can also be seen in COVID pneumonia. Very good. So I can see many of you are able to answer this. Okay. Now, very intelligent students. Now we go forward. Now what I will do is, I will give you an idea on more cardiac diseases. Okay, we'll look at some more cardiac diseases, but to see them, we need to know the normal anatomy. So if I zoom the X-ray for you, please see with me. Okay, this is your left atrium. Okay, this is your left atrium. And I want you to appreciate, I want you all to appreciate that, look at this structure. This is your auricle that I was talking about, the left auricle, the left atrial appendage. So do you now understand? Listen to me. Do you now understand that the chest X-ray left atrial appendage or the auricle is forming a part of the left heart border? Left atrium heart border को touch नहीं कर रहा, auricle करता है. Okay. Now let's see if you can answer. Okay. Let's see an answer. Ground glass appearance is a CT finding. We cannot say ground glass on a X-ray. Okay, ground glass is CT finding. Okay, anybody now? Have you heard of a disease called as rheumatic heart disease? In rheumatic heart disease, typically you have a disease involving the mitral valve. Okay, so if you have a mitral valvular disease, listen to me, the left auricle starts to bulge in this direction. If you have mitral stenosis, mitral regurgitation, the left auricle starts to bulge in this direction. So now the question that I want you to understand is, the first chest X-ray sign of rheumatic heart disease is left auricular bulge. Okay, first chest X-ray finding of rheumatic heart disease is left auricular bulge, and which is actually the beginning of straightening of the heart border. Because of the auricle bulging, now the heart border will start to become straightened. Have you ever heard of this before? Have you ever heard? Okay, so remember, COVID-19, the whatever findings I have told you are all CT findings. We've only talked about CT findings, beta. Okay, now because chest X-ray is not sensitive to pick up those findings, we usually pick them up on a CT scan. Okay, so first X-ray finding of rheumatic heart disease, left auricular bulge leading to straightening of the heart border. Now see the second chamber that I want you to see. Now the cardiac chamber that I am trying to highlight for you is right atrium. Okay. Now imagine somebody having a disease in the tricuspid valve. What will happen to the RA? There will be RA enlargement. Do you agree? So if there is a tricuspid valve disease, there will be right atrial enlargement. So can you name a disease in which, beta ji, can you name a disease in which the tricuspid valve is lower than normal position? अपनी जगह से नीचे होता है. Okay, anybody? That is Epstein's anomaly that you might have studied in pharma when they were talking about lithium. Remember, lithium treatment in the mother can lead to Epstein's anomaly. Okay, straightening of the left heart border was what we were talking about, Epstein's. And second disease where the tricuspid valve is diseased is tricuspid atresia. Okay, don't draw this, just note it down. I will show you the real X-ray later on just to understand. Let's try and imagine now somebody has Epstein's anomaly or somebody has tricuspid atresia. What will happen to the right atrium? The right atrium will become enlarged. Okay, we are free, we are enjoying, we are just making a painting. Right atrium इस तरफ पे बड़ा होना शुरू हो जाएगा. Because the problem is the tricuspid valve, the right atrium becomes enlarged. Okay. Now when the right atrium massively enlarges, it also lifts up the apex. Apex usually right ventricular enlargement में rounding होगा, लेकिन यहाँ पे apex की rounding भी हो जाएगी. Okay. So let's again answer. Listen to me. In tricuspid valve disease like Epstein's and tricuspid atresia, the right atrium enlarges, and because of massive enlargement of right atrium, the apex is also lifted up. Okay. अब एक बात बताओ बेटा. Okay. Let's see if you can answer. If there is a disease in the tricuspid valve, okay, so blood from right atrium cannot go into the right ventricle. So if less blood is going into the right ventricle, that means less blood is going into the pulmonary artery. So the pulmonary artery will be narrow. So what will happen is this area where we have the aorta and the pulmonary artery will be narrow. The area where we have the aorta and the pulmonary artery will be narrow. Because of the tricuspid valve disease, the pulmonary artery will be narrow. So this is how the heart would look like. Okay, don't make it, just understand. Okay, I will show you later on. So the heart will actually look like this. Narrow vascular pedicle. Bulge on the right side because of the RA, and this bulge because of the apex lifted up. What is this? Box-shaped heart. Now, this is the reasoning why you have box-shaped heart both in Epstein's as well as tricuspid atresia. Are you clear? Box-shaped heart is a feature of, and I'm removing. Box कैसा है? देखो, box इसको कह रहे हैं. ऊपर से पतला था, suddenly ऐसा हो गया. Like this. So we call it box-shaped heart. Box-shaped heart seen in Epstein's anomaly, tricuspid atresia. This is not money bag. Money bag ऐसा नहीं होता. Money bag बाद में दिखाऊंगा. हाँ? Okay. So this is called as box-shaped heart. Let's understand. So the only moral of the story that we have drawn so far is, in rheumatic heart disease, the characteristic valve that is involved is mitral valve, and that is why we had auricular bulge. While in Epstein's and tricuspid atresia, the valve that is involved is the tricuspid valve, and that is why you have RA enlargement, and that leads to the box-shaped heart. Okay, now see an answer. Now, as I go more anterior, you can see a cardiac chamber that I'm labeling. This is your left ventricle. Now, left ventricle forms the apex of the heart. And please notice it here. Please focus and notice it here. Without judging, just understand. The apex is going below the diaphragm. Can you notice it here? Apex जो है diaphragm के नीचे जा रहा है. So this is how the normal apex should be. A normal apex, narrow vascular pedicle was the what I had written. I will write it again. Don't worry, I will write it again. So left ventricle forms the apex, and apex goes slightly below the diaphragm. This is how the normal contour should be. Okay, and the anterior most chamber of the heart is right ventricle. Anterior most chamber of the heart is the right ventricle. Can anybody tell me if the right ventricle is enlarged, how, in which direction it will enlarge? If the right ventricle is enlarged, it enlarges in this direction. So we will say upward, outward. So the apex will be lifted up in an upward, outward direction. So this is where we will look at when we see the X-rays. I will help you when we see the X-rays. I will help you to find out if there is a upward, outward shift of the apex. This we will utilize when we look at an X-ray of tetralogy of Fallot. In tetralogy of Fallot, the apex will be lifted up, giving rise to a rounded contour because of the RV hypertrophy. Everybody gets it? Now, so why we had a narrow vascular pedicle is, but if you have a right atrial disease, right atrium में बीमारी है, tricuspid valve में बीमारी है, so the blood is not going into the right ventricle, less blood is going into right ventricle, less goes into the pulmonary artery. So the pulmonary artery is narrower than usual. So that leads to the narrow pedicle. Okay, now let's see an answer, beta. Now, if I ask you on a lateral view, things are very simple to understand once you understand the orientation of the heart. Everybody notice, heart is placed like this. Okay, heart in the chest is placed like this. Okay, let me make it slightly better. Okay. Okay, so the moral of the story is, whatever I'm drawing here is, the only reason I want you to draw this is because I want you to remember, right ventricle is the anterior most chamber, left atrium is the posterior most chamber. Okay, everybody gets the concept or not? है ना? Heart को समझना है तो ये जरूर याद करना पड़ेगा. Okay, because right ventricle, I told you in the previous image, some of you are unable to get it, right ventricle enlarges in an upward, outward direction. This is the direction of enlargement of right ventricle. I will show you the X-ray later on, and when we see the disease, it will become more clear to you. So what happens in the heart is, it is the right-sided chambers which are anteriorly placed, left-sided chamber which are posteriorly placed. है ना? अब let's see if you can answer better. Anybody can answer. This is where you have your trachea. Okay, and trachea is sitting in relation to the left atrium. Trachea is sitting right next to the left atrium. Okay, so this is the trachea, and this point where the trachea ends is called as the carina. And behind the trachea we have the esophagus. Behind the trachea we have the esophagus. Okay, now anybody of you now looking at this anatomy, you have to do an applied anatomy question. Retrosternal space obliteration on a chest X-ray is seen due to enlargement of which cardiac chamber? Retrosternal, okay, listen to me. Retrosternal space obliteration, okay, on a chest X-ray is seen due to enlargement of right ventricular enlargement. Do you understand this or not? Because this is the space. Can you see there is a space between the sternum and the heart? This space will be obliterated if you have right ventricular enlargement. If they ask you more than one answer, then even right atrial enlargement can lead to this. Okay, anybody? Posterior displacement of esophagus will be caused by So if they ask you this, it's very simple. Esophagus पीछे की तरफ है, पीछे की तरफ तो left atrium है. Okay, so it is due to left atrial enlargement. Posterior displacement of esophagus is because of left atrial enlargement. Very good. And if I now say carinal angle widening is due to which cardiac chamber enlargement? So carinal angle widening is again due to left atrial enlargement. So simple logics, we could understand those simple logics based on our simple understanding of the anatomy. But if we don't understand the anatomy, if I go straight to X-ray, you will not be able to follow. That is why I always go from the basics. Everybody clear? ओके समझ पा रहे हैं कि नहीं बच्चे? इसोफेगस पीछे, लेफ्ट एट्रियम पीछे, इसलिए तो वो उसको कंप्रेस करेगा अगर बड़ा होगा तो, और यहीं पे कराइना है तो इसको बड़ा, इसको भी वाइडन करेगा. ओके, everybody understands? Okay, now let's look at a cardiac image. Okay, let's look at this X-ray together, and I'll ask you to solve the X-ray for me. Anybody? In the next X-ray that we are looking at, what is the size of the heart? What is the size? Heart is enlarged. There is cardiomegaly. Is this a mild cardiomegaly or massive cardiomegaly? This is massive cardiomegaly. Do you agree? So as soon as we see this X-ray, I know we are dealing with a massive cardiomegaly. Massive, बहुत बड़ा heart है, बहुत ही बड़ा है ना, बड़ा दिल है इसका, है ना? Let's see if you can answer better. Okay, anybody? Now, if you have a heart this big, suppose you are having a heart failure and your heart is dilated so big, या dilated cardiomyopathy आपको, या heart failure है, heart इतना बड़ा हो गया. Okay, so तो lungs कैसी होनी चाहिए बेटा? एक बात बताओ, if you have a massively dilated heart because of failure or a cardiomyopathy, the lungs में क्या होना चाहिए? Do you remember, if there is a heart failure, the lungs should have edema. But in this patient, the lungs are clear. Lungs are clear. Which is the thing that I need to understand. इतना बड़ा heart है लेकिन lungs एकदम साफ कैसे हैं? There's no edema, no battening appearance. ऐसा कैसे हो सकता है? Now, when I look at the shape of the heart is shaped like this. The enlarged heart is conical in shape, or we can say flask shaped, or we can say like a money bag, and there is no specific chamber enlargement sign. मतलब ऐसा नहीं है कि केवल राइट साइड पे बड़ा है या केवल लेफ्ट पे बड़ा है, ऐसा नहीं है ना. सो देयर इज लाइक, ऐसा नहीं है ना ओनली राइट एट्रियम इज एनलार्ज, ओनली लेफ्ट एट्रियम. इट इज द एंटायर कार्डियक silhouette which is enlarged in a conical money bag flask like manner. There is no single chamber enlarged. What do you think? That is where we think this is not the heart, this is pericardium which is full of fluid, this is pericardial effusion. समझ आया कि नहीं? क्यों पेरिकार्डियल इफ्यूजन है? बहुत बड़ा हार्ट है लेकिन लंग्स डिस्प्रोपोर्शनेटली क्लियर है, हार्ट का शेप मनी बैग जैसा है, कोई सिंगल चैम्बर एनलार्जमेंट नहीं. इफ यू सी दिस यू विल कॉल इट एज पेरिकार्डियल इफ्यूजन. Okay, this is how you suspect pericardial effusion. If you have a disproportionate cardiomegaly with clear lungs, I am always suspicious as a doctor. What is the investigation of choice for pericardial effusion? Investigation of choice for pericardial effusion is echocardiography. Investigation of choice for pericardial effusion is echocardiography. What is echocardiography? Fancy name for cardiac ultrasound. Okay, anybody? What is echocardiography? Fancy name for cardiac ultrasound. Now, how to identify pericardial effusion? Just see with me. एक बार देख लो. This is how on echo the heart looks like. Okay, this is the heart on the echocardiogram. Can you see there is this black area surrounding the heart? दिख रहा है? अब मैं मिटाता हूं, देख लो. Can you see surrounding the heart there is a black area which is now marked? That is pericardial effusion. So if you see the cardiac chambers with, you can see there is a surrounding fluid, this is pericardial effusion on your echocardiogram. Are you clear? Okay, everybody understands. Now let's go further. Okay, now to go further I will make a small table in front of you. Okay, a small table, but last NEET exam, last NEET PG 2020, from my table there were 3 questions. Okay, listen to me everybody. If suppose you are suspecting a congenital heart disease in a child, पढ़ा आप लोगों ने अभी तक? So first thing that you need to look at clinically is साइनोसिस है मरीज को कि एसाइनोटिक है. Okay, so in the question also you should look for, don't jump to solve the x-ray without looking at the clinical history. x-ray नहीं बता पाएगा, clinically देखना पड़ेगा कि साइनोसिस है कि नहीं. Because once we know साइनोसिस है या नहीं है, we will be able to narrow down our differential diagnosis. Okay, everybody, now see. So in lungs, you remember in the chest x-ray, listen to me, in the chest x-ray, lungs के अंदर we see bronchovascular markings, we can see the marking of the blood vessels. अगर bronchovascular marking कम है तो we call it oligemia. Olig मतलब कम. ओके, अगर पेशेंट को साइनोसिस है और लंग्स में, उसके चेस्ट एक्सरे में लंग्स में ओलिगीमिया है, ओके, और उसका हार्ट का शेप बूट के जैसा है, then we make a diagnosis of tetralogy of Fallot. Everybody understands? Are you clear or not? Name a congenital heart disease where you have cyanosis, oligemia in the lungs, shape of the heart is like a boot, tetralogy of Fallot. If the shape of the heart is like a box, then we go for things like Epstein's anomaly and tricuspid atresia. समझ आया? Okay, साइनोसिस है बच्चे को. आई कैन सी सम ऑफ यू आर एबल टू आंसर, विच इज वेरी गुड, है ना. थोड़ा सा पीडियाट्रिक्स का पार्ट भी कर लेते हैं, बहुत जरूरी है. एंड दिस इज व्हाट दे आस्क्ड इन द लास्ट एग्जाम, प्लीज सी वेरी केयरफुली, है ना. ओके, ऑलिग मतलब कम, इमिया मतलब ब्लड. लंग्स में ब्लड वेसल के निशान कम है तो इसे ऑलिगीमिया. ओके, डू यू अंडरस्टैंड? ऑलिगीमिया मतलब, ऑलिग मतलब कम होता है, इमिया मतलब ब्लड. लंग के अंदर ब्लड वेसल्स दिखेंगी ना एक्सरे में व्हाइट व्हाइट लाइंस की तरह, वो कम होना ऑलिगीमिया. Reduced vascular markings in the lungs is called as oligemia. Okay, very good now. So if the heart is shaped like a box, then you think of Epstein's and tricuspid atresia. If you have increased vessels, more vessels in the lung than normal, we will call it plethora. प्लेथोरा मतलब होता है एक्सेस. अगर मरीज को क्लिनिकली साइनोसिस है, एक्सरे पे लंग में बहुत ज्यादा लाइंस दिख रही हैं, so the patient has cyanosis clinically, but the lungs have increased vascularity. Okay, then we will call it plethora. Oligemia मतलब reduced vascularity beta. Increased vascularity is plethora. Then remember, if the heart is shaped like a snowman, snowman कैसा होता है? ऐसे 8 नंबर जैसा. So if the heart is shaped like a snowman, then we make a diagnosis of TAPVC. अभी बताऊंगा क्या होता है. TAPVC, total anomalous pulmonary venous connection. If the heart is shaped like a acorn side, then we call it TGA. Okay, I will show you all of this. Don't worry, मैं सब दिखाऊंगा, घबराएंगे नहीं. Okay, but the key is ये पूरा मेरा चार्ट पता होना चाहिए. क्लिनिकली साइनोसिस होगा, एक्सरे पे लंग्स में इंक्रीज वैस्कुलरिटी, शेप ऑफ द हार्ट लाइक अ स्नोमैन, देन TAPVC, acorn side, TGA. Acyanotic heart disease with pulmonary plethora is left to right shunts. Okay, साइनोसिस नहीं है और लंग में वैस्कुलरिटी ज्यादा है, कंजेनिटल हार्ट डिजीज में थिंक ऑफ लेफ्ट टू राइट शंट्स. लेफ्ट टू राइट शंट्स कैन बी थिंग्स लाइक ASD, VSD, PDA. पढ़ा था एट्रियल सेप्टल डिफेक्ट, वेंटिकुलर सेप्टल डिफेक्ट. नाउ रिमेंबर, if on echo they say left atrium is normal, go for ASD. If they say left atrium is enlarged, go for VSD. This is the differentiating feature on echo. Okay, so remember, if you have acyanotic heart disease, there is no cyanosis, but the lungs have increased vascularity. Think of things like ASD, VSD. Left atrium, if it is normal on echo, normal size, then we go for ASD. If it is enlarged, then we go for VSD. Okay, let's now this is the background. Another thing I want you to remember is, if there is no cyanosis, but aorta is shaped like figure of 3, and you have inferior rib notching in 3rd to 8th ribs, you will make a diagnosis of coarctation of aorta. This inferior rib notching is called as Dock sign. अगर कंजेनिटल हार्ट डिजीज है लेकिन कोई साइनोसिस नहीं है, अयोटा फिगर ऑफ 3 के जैसा है, inferior rib notching है जिसको डॉक साइन कहते हैं, that is only seen in 3rd to 8th ribs, we think of coarctation of aorta. coarctation of aorta कहां पढ़ी आपने? टर्नर सिंड्रोम में पढ़ी थी ना. टर्नर सिंड्रोम में coarctation of aorta होता है. Brilliant. Okay, so this is what you will read in detail when your pediatrics classes will also happen, but in the exam we need to know something about their radiology. I will show you what I mean. Okay, I will show you what I mean before we finish the cardiac imaging. Please look at these x-rays with me. This is a very common x-ray asked in the exam. Okay, now if you notice now, can you see this is a heart which is shaped like this? What is this? This is a boot, also called as cor en sabot, seen in tetralogy of Fallet. Can any of you beta ji tell me, why are the lungs appearing so black? इस एक्सरे में lungs इतना black क्यों है? Where are the vessels? Why we cannot see the vessels? Do you agree? बहुत कम है ना vessels? Because the lung, this is a right to left shunt called as tetralogy of Fallet. And in this patient, the lungs have oligemia. Clear? Boot-shaped heart, Corin Sabot, tetralogy of Fallot with oligemia. Very good. Now I can see, a lot of you are able to answer. Okay. Okay. See the next X-ray now. Now compare the lungs in these two X-rays. Compare the lungs in these two X-rays. Do you agree in the second X-ray, the lungs have a lot of white areas as compared to the previous X-ray? Can you see? In this X-ray, there are a lot of white areas. That means there is plethora. Increased amount of blood in the lung will lead to more white lines, more white patches, plethora. Okay. This patient also has cyanosis. Clinically, they are saying cyanosis. But the shape of the heart is like this. This is what is called as snowman heart, figure of 8 heart, cottage loaf heart on chest X-ray, seen in total anomalous pulmonary venous connection. Keywords to look for in the question are plethora, cyanosis, shape of the heart. TAPVC का मतलब होता है total anomalous pulmonary venous connection. ठीक है बेटा? Very good. I can see some of you are able to answer. Very good, beta. Very good. Now look at the next X-ray. Now in the question they will say a newborn. पहले में child था, ये newborn है with cyanosis. ऐसा लिखा होगा. Lungs have increased vascularity. We will call it plethora. Lungs में ज़्यादा white areas हैं. The heart is shaped like this. This is called as egg on side heart. Answer is TGA. So this is called as egg on side heart, which is seen in transposition of great artery. TGA is of two types. So this appearance is only seen in uncorrected TGA. Just to keep it in mind, you will read about it later on, but just keep it in mind that only in uncorrected TGA you will see egg on side heart. And the classic history will be saying a newborn with cyanosis. Okay, that is very important. And lungs will be plethoric. Plethora matlab zyada, oligemia matlab kam. Very good. Now, the final picture here, before we are, I will about to go to the next topic here. The final picture here is, please see an answer. Okay, narrow vascular pedicle. Okay, that means this area is narrow. Then this is like this, like this. What do you think? A heart shaped like a box. This is Epstein's. The underlying cause is massive enlargement of right atrium. So to see the difference between the pericardial effusion and the Epstein's, in Epstein's, I'm sure you can pick it up. This area is very narrow, suddenly starts to bulge. While in pericardial effusion, it was more conical. This is your Epstein's anomaly. Epstein's anomaly, again, you will say cyanosis with box-shaped heart, RA enlargement, box-shaped heart, narrow vascular pedicle. We think of words like Epstein's. Okay, very good. So once you're able to answer this, quickly before going on to the next topic, just tell me, is there any role of cardiac MRI today? Okay, we saw the cardiac CT in the beginning of my classes, but is it possible to do a cardiac MR? Is it possible? Okay, I'm going very slow, beta. Okay, is it possible to do a cardiac MR? Answer is yes. Why would you do cardiac MRI? Remember the magic word here, okay? Cardiac MRI is nowadays being used for myocardial disorders. Okay, cardiac MRI is nowadays being used for myocardial disorders, which is very important today. You might not have known all this, but it's very important. Suppose you have a myocardial long-standing scar and you want to characterize it, you will do a MRI, myocardial scar. If you have myocardial iron deposit due to repeated blood transfusion, that is called as hemochromatosis. Remember, you might have read about this. So even in hemochromatosis, today to see iron deposit in the myocardium, we do a MRI. In myocardium, you can also have amyloid deposit, which you might have studied in your pathology when they talked about amyloidosis. This can be diagnosed on cardiac MR. And if you have right ventricular wall with fibrofatty replacement of the right ventricle in a disease of the desmosomes, that is called as arrhythmiogenic right ventricular cardiomyopathy. Did you read about this in pathology? ARVC. ARVC क्या होता है? डेस्मोसोम की बीमारी है बेटा, नहीं पढ़ी तो पढ़ के देखना, अच्छा लगेगा जब जाएंगे. इसमें राइट वेंट्रिकल में फाइब्रोफैटी रिप्लेसमेंट होता है. ओके, नाउ द कॉमन थिंग इन द टेबल दैट आई हैव ड्रॉन इज, ओके लिसन टू मी, तीनों में एक मायोकार्डियम में बीमारी है. एक में मायोकार्डियम में स्कार हो गया, एक में आयरन जमा हो गया, एक में अमाइलॉइड जमा हो गया, एक में फैटी रिप्लेसमेंट हो गया. Today, for all of them, the investigation of choice is a cardiac MR. Non-invasively MRI करते हैं. अब we are able to tell amyloid है कि वहां पे iron है कि, okay, we are able to tell is it a scar, is it ARVC. Clear here, very important for you to know. Second thing to keep in mind is MRI is today the gold standard to assess ventricular function. MRI को गोल्ड स्टैंडर्ड माना जा सकता है वेंट्रिकुलर फंक्शन का. इट कैन टेल यू द इजेक्शन फ्रैक्शन. वेंट्रिकुलर फंक्शन का क्या मतलब होता है? वेंट्रिकुलर फंक्शन मींस थिंग्स लाइक इजेक्शन फ्रैक्शन, स्ट्रोक वॉल्यूम एंड कार्डियक कॉन्ट्रैक्टिलिटी. MRI is also indicated to assess pericardial thickness and cardiac tumors. So this is only thing that you need to know as a MBBS graduate. Even as a MD medicine, this is what you would need to know. कि भाई MRI करवाना कहाँ पे, किस कारण से कराना होगा हार्ट में MRI. So MRI is the gold standard for ventricular function assessment. Ventricular function assessment means ejection fraction, stroke volume, cardiac contractility, and it is the investigation of choice for pericardial thickness assessment and cardiac tumors. Pericardial thickness, cardiac tumors. Okay. Now, how does it look like? Let's try to understand before we go forward. How does it look like? Have you ever seen a cardiac MR? Okay, let's see if we can show you. Okay. Okay, let me show you how a cardiac MRI looks like. Okay, now this is different from a brain. In brain we talked about diffusion weighted MRI, है ना. Heart में तो वो catheter angiogram वगैरह करेंगे ना. So this is how cardiac MRI looks like. So cardiac MRI, this is how you can see the beating heart in high resolution. Okay, just spend a moment here to appreciate the beauty of cardiac MRI. Okay, this is how beautiful cardiac MRI looks like. इससे सुंदर कुछ नहीं दिख सकता. Okay. Clear? Do you agree, Kenny? Is that beautiful? Do you want to take it home? Yes, beautiful. Can you see? This is how beautiful the cardiac MRI looks like. You can see every wall contracting. You can comment on the wall contractility. You can comment on the stroke volumes, ejection fraction. This is the gold standard for cardiac MRI is the gold standard for ventricular function assessment today. This is how it looks like. Interesting? Okay, very good. So all of you smart children have been able to answer. Now tell me. Okay, so with this, you've got an idea that acha cardiac MRI hota hai, because I've seen sometimes children sitting in a peripheral medical college may not even know all this. है ना, वो सोचता है MRI होता ही नहीं है, और होता ही नहीं है तो गलत कर देता है. You agree here or not? Do you understand? So sometimes a intern or a MBBS student will come to me and say, sir, cardiac MRI मैंने तो नहीं देखा, होता थोड़ी होगा. So मैं कहता हूँ तूने नहीं देखा तो इसका ये मतलब थोड़ी होता नहीं है. Do you understand this or not? Okay, it's a day-to-day thing which is happening, but sometimes in periphery you may not have seen it, and you might be thinking because you have not seen it does not exist. It is not true. Okay, it is not true. It is very common to do cardiac MRI today. Okay, my question is, only myocardial condition where we will not mark the answer as MRI is myocardial viability. If we have to assess myocardial viability, I will talk about this later on when I talk about PET scan. Just remember here, for myocardial disease, we will mark MRI most of the time, but for myocardial viability, PET scan is better than MRI. For myocardial viability, PET scan is better than MRI. Everybody clear? Everybody understands? Okay, for myocardial viability, बेटा किसी के हार्ट में amyloidosis दिखना है, amyloidosis, iron deposit, तो you'll get an MRI done. Okay, everybody understands this or not? ये बोलना कि देखिए बच्चे, so that is the difference between periphery and central institutes बेटा. So when you are studying in a central institute, you will see things happening. भाई देखो ना, पेरिफ्री में अगर आप बैठे होगे वो बोलेगा कि जेनेटिक्स देख के क्या करना है, जेनेटिक तो कोई इलाज ही नहीं होता. When you start working in places like JIPMER and AIMS, you will find they will be doing genetic treatment also, and they will be talking about CRISPR, genetic engineering. Then you can't say कि होता नहीं है. Okay, everybody understands? Okay, now we come to the next topic of the day, which is bone. Now I'll just revise for you in a moment. I'll just revise for you. So this is the end of the chest X-ray that we had started. We have now seen how to look at a CT scan. We have seen how to look at MRI. We have seen how to look at chest X-ray. We have seen the neuro imaging. Okay, these are the most important parts of the X-ray. Now I will start with orthopedic imaging. I will give you a beginning today, and we will go further into it in the next class also. And today I will start in orthopedic imaging. I will talk about bone tumors. Okay, everybody? Okay, we'll talk about bone tumors. Now let's see if you can answer. Let's see if you can answer better. So first of all, I will only tell you the basic concept behind a X-ray approach to a bone tumor, and then we will see practically. Okay, beta. I will first show you the basic approach, then I will show you practically. Okay, some of you might have studied this before, but let's see if you can answer. There are 5 steps to look at an X-ray of a bone tumor. There are 5 steps to look at an X-ray of a bone tumor. Step number 1. Step number 1 क्या है बताओ बच्चे? Step number 1 is, please look for growth plate. Okay. Step number 1, look for growth plate. What is growth plate? Do you remember the growth plate is a gap between the metaphysis and the epiphysis? Okay. So remember, growth plate अगर दिख रहा है तो that means we are looking at an immature skeleton. नहीं दिख रहा तो mature skeleton. Everybody understands? So step number 1, as soon as you look at an X-ray of a bone tumor, is please look for growth plate. because the diagnosis will be different in an adult and a child, I need to have an idea, am I looking at an immature skeleton or a mature skeleton? This सबसे पहला बेटा, okay? Everybody understands? Look for growth plate. Am I looking at an immature skeleton or a mature skeleton? Very good. Now, step number 2. कितने total step बताए मैंने? 5. Now we are at the step number 2. Step number 2 is location. Okay. Location में, first thing you need to tell me is, are you looking at a single lesion or multiple lesion? Okay. Is the tumor that we are looking at, is it single or multiple? बेटा बताओ. अगर multiple है तो क्या हो सकता है? It could be metastasis. It may not be a primary tumor, it could be metastasis. Second, it could be a hematological condition. पढ़ा था वो प्लाज्मा सेल वाला मल्टीपल माइलोमा. इट कुड बी अ बोन में दिख रहा है लेकिन हो सकता है मल्टीपल माइलोमा. तीसरा, it could be a syndrome. There are some syndromes which are associated with bone tumors. It could be one of those. Or it could be a metabolic condition causing bone destruction that is called as hyperparathyroidism. डू यू एग्री कि नहीं? ठीक है. सबसे पहले देखा ग्रोथ प्लेट दिख रही है कि नहीं दिख रही. अगर दिख रही है तो बच्चा है, अगर बंद हो चुकी है तो अडल्ट है बेटा, है ना? ठीक है कि नहीं बेटा? अगर बंद हो गई ग्रोथ प्लेट तो अडल्ट है. यू अंडरस्टैंड माय पॉइंट और नॉट? इफ ग्रोथ प्लेट इज क्लोज, दैट इज अडल्ट. ओके. नाउ इफ वी लुक एट द लोकेशन, देन वी लुक एट द लोकेशन. बेटा सुने, लोकेशन में आपने सबसे पहले देखना सिंगल है कि मल्टीपल है. इफ द डिजीज इज मल्टीपल, आई स्टार्ट थिंकिंग ऑफ metastasis, hematological disorders, syndromes, metabolic disorders. Clear? Then I look at, is it a flat bone or a long bone? Then I look for, is the disease involving the epiphysis or metaphysis or diaphysis? ठीक है. So these are the questions that we need to answer. We need to know, am I looking at a bone lesion? Is it a single lesion or multiple lesions? Is it a flat bone lesion or a long bone lesion? Is it epiphyseal, metaphyseal or diaphyseal? This will help me to solve the puzzle that we are looking at. Now we come to step number 3. Step number 3 is look for pattern of destruction. Step number 3 is look for pattern of destruction. If a tumor is causing well marginated destruction, that means you can make out the margins easily, it is well marginated lesion, you are thinking of benign, I will call it as geographic lytic lesion. Okay, that means if I'm able to take a pen, listen to me, if I'm able to take a pen and draw an outline around the tumor, I will call it geographic lytic lesion. ठीक है. अब बताओ, geographic lytic lesion ज्यादातर benign बीमारी में मिलेगा. ठीक है. If it is aggressive pattern, I will not be able to see the margins. I will use the words like moth-eaten destruction, or I will use a word permeative destruction. ठीक है बेटा, आपने बताना है. Suppose they say geographic lytic lesion, automatically you should think of a benign disorder. If they say permeative destruction, you should think of malignancy. I will show you what is the difference when we look at the x-rays. So step number 1 was, please see the age by looking at the growth plates. Step number 2 was, टेल मी स्टेप नंबर 2 क्या था? लोकेशन. स्टेप नंबर 3 पैटर्न ऑफ डिस्ट्रक्शन. What is step number 4? Step number 4 is please look for matrix. Step number 4 है matrix को देखो. Matrix. Now there are tumors which are producing osteoid. There are tumors which are producing chondroid, okay, which can be identified, and there are tumors which have no matrix. Okay, so do we have a identifiable matrix? कौन से मैट्रिक्स हम पहचान सकते हैं? We can identify osteoid, we can identify chondroid. If a tumor is producing osteoid, listen to me, osteoid बना रहा है तो क्या होगा? On osteoid, the mineral will be laid down in a dense ivory-like manner. Osteoid के ऊपर जो मिनरल जमा होगा, it will be dense ivory-like manner. Okay, ट्यूमर में मैट्रिक्स देखना है. ट्यूमर जहां बोन को डिस्ट्रॉय कर रहा है, उसके अंदर ग्राउंड सब्सटेंस को मैट्रिक्स कहेंगे, लक्ष्य अरोड़ा. सो ये पैथोलॉजी में भी लिखा था, अगर आपको याद हो, कि बोन ट्यूमर्स कैन बी क्लासिफाइड इनटू ओस्टियोइड प्रोड्यूसिंग, कॉन्ड्रॉइड प्रोड्यूसिंग. दैट इज द मैट्रिक्स बेटा. हाँ, देखो कॉन्ड्रॉइड जब होगा ना, सो कॉन्ड्रॉइड में मिनरलाइजेशन विल बी लाइक दिस, डॉट डॉट डॉट. सो वी कॉल इट स्टिपल्ड. Sometimes this dot 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 will be larger and coalescent like this. Then we use a word flocculent calcification or popcorn calcification. Chondroid tumor can also lead to calcification in form of arcs and rings pattern. ठीक है, अब समझ के बताना है मुझे. अगर पूरा ट्यूमर में जो अंदर जो उसका डिस्ट्रक्शन है वो पूरा होमोजेनस है, व्हाइट है, आइवरी जैसा, तो ओस्टियोइड प्रोड्यूसिंग है. अगर उसके अंदर डॉट 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 है, फ्लॉकुलेंस है, स्टिपल्ड है, पॉपकॉर्न अपीयरेंस है, आर्क्स एंड रिंग्स है, तो दैट इज द mark of a chondroid tumor. So we are able to differentiate on an X-ray, looking at the matrix, that what kind of tumor is it. Okay, now let's see if you can answer. Step number 5. कितने स्टेप थे? 5. फाइनल स्टेप आ गया. स्टेप नंबर 5. आप इसके बाद सिर्फ प्रैक्टिकल दिखाऊंगा, है ना, सिर्फ थ्योरी थोड़ा सा. स्टेप नंबर 5. स्टेप नंबर 5 इज लुक फॉर extension beyond the bone. जो हम बीमारी देख रहे हैं, is it limited to the bone or is it outside the bone also? मतलब अब that means you can understand, if it is a malignant process, it will break the cortex of the bone and it will come out. That means first thing we are looking for is we are looking for cortical break. जहां पे बोन में डिजीज है, डू यू हैव अ cortical break or not? Okay, let's try to understand. Okay, I'm repeating. Let's see an answer beta. Okay, now suppose this is a bone, this is another patient, and this is the bone. Suppose in the bone you have some disease. Suppose in the bone you have some disease. If it is an aggressive malignant process, it will break the bone and destroy the bone. Okay, but sometimes you will see a break like this. What is the difference between the two? In the first image, there is not only a break in cortex, a piece of bone, a fragment of bone is missing. Why it is missing? Because it is destroyed. That means we are looking at an invasion. It is an invasive process, a malignant process. In the second image, although there is a break, in the diseased part of the bone there is a break, but there is no missing fragment. This is where I will use a term pathological fracture. I will not call it invasion. I will say pathological fracture. Everybody understands? Are you able to follow my point or not? Okay. So that means a malignant tumor should extend beyond the bone. So if a tumor is extending beyond the bone, there should be a cortical break. But mind you, not all cortical breaks will indicate invasion. If there is a break with no missing fragment, I will call it pathological fracture. I will not call it invasion. Everybody understands this concept? Okay, very conceptual. Now, second concept is, okay, let's understand, suppose this is the bone. If there is a disease which comes out of the bone, this disease will lead to elevation of periosteum. Any disease which comes out of the bone will lead to elevation of the periosteum. Whenever periosteum is elevated, a thin shell of mineral deposits over it. It gets mineralized. That is called as periosteal reaction. समझ आया कि नहीं? समझ आया बच्चे कि नहीं? Everybody understands or not? Okay, periosteal reaction means X-ray visible periosteal elevation. Any disease which goes outside the bone. Yeah, Abhishek, you are able to talk to Shalu in Hindi, but you're not telling me like this. What is this, huh? Okay, let's see an answer, beta. Continuous lamellar periosteal reaction. Okay, everybody now, let's see. Listen to me, an answer. Okay, if the periosteum is elevated, but you see a continuous shell of bone over it, continuous, that means we are looking at a short duration benign illness like acute osteomyelitis. Okay, everybody understands? Okay, second question is, let's see if you can answer. So, there are things where language is no barrier at all. Okay, let's see an answer, beta. Now understand, okay, listen to me, everybody now, stop, listen to me. If it is a long-standing chronic disorder, the periosteum which has elevated will form new bone below it. This is called as solid periosteal reaction, typically seen in long-standing benign disorders like chronic osteomyelitis. Okay. Are you clear? Are you able to understand this or not? Are you able to follow my point? That if you have a benign disorder, you will see periosteal elevation. But if it is a short duration, acute onset disorder, okay, the periosteal shell will become ossified. If it is a chronic disorder, you will see new bone formation, solid new bone formation. Okay, everybody understands. Now let's see if you can answer. Now I want you today to imagine, beta, everybody now focus on it. Focus on it, beta. Abhi usko ruk jayenge, beta. Let's stop on the chat box and listen to me. Otherwise, you will not be able to understand. Very important. Okay. Let's imagine a tumor or a disease coming out of the bone which grows in alternate slow and fast phases. Let's imagine a disease which is growing out of the bone in a very aggressive, fast manner. And when it grows out of the bone, it is destroying and coming out. Then suddenly it has a slow phase. Whenever you have a slow phase, the periosteum deposits mineral and a shell of mineral is deposited. Then after some time, it again starts to grow fast. Now what happens? Again, it is growing. No time for periosteum to mineralize. Then grows slow. Periosteum deposits a shell of mineral. Then again starts to grow fast. Then again becomes stop. Now, can you now think of it Can you now think of it and tell me, okay, name a tumor which grows in alternate fast and slow phases. Alternate fast and slow phases. This is a multilamellar appearance. In your pathology book, they have used a term onion peel periosteal reaction. Seen in where? Ewing's sarcoma. Concept formed. So now you understand, when we were looking at a single layer of periosteum, I said it's a benign disorder. But when I see multiple layer, I'm saying it's a malignancy, it's a sarcoma. Sarcoma matlab malignant hota hai beta, sarcoma. Okay, that's Ewing sarcoma. We are able to see multiple layers of periosteal reaction, telling me that this disease has alternate slow and fast growth. Very good. Now let's see if you can answer more. Okay, let's see if you can answer more. Okay, बेटा देखना थोड़ा सा मुश्किल है बेटा, but I want every one of you to look at the screen very importantly, because these are very important concepts. If this is the bone, this is the bone. You know by now, bone is covered by periosteum. Bone is covered by periosteum. And bone and periosteum are connected together by fibers called as Sharpie's fibers. So periosteum is attached to the bone by fibers called as Sharpie's fibers. Okay. Everybody remembers? Bone is covered by periosteum. Periosteum is attached to the bone with Sharpie's fiber. Now I want everybody to only look at the screen. Abhi likhenge nahi. Okay, just look at the screen. Don't write down. Very, very important thing. Otherwise, you will keep missing it. Okay, very, very important. Okay, don't look at the screen, beta. Okay, okay, don't look at your copy. Only the screen. Don't look at your copy. Okay, listen to me. Listen to me. Now imagine a tumor which destroys your bone, destroys your periosteum, and is growing like this. Imagine a tumor which is aggressive tumor coming out of the bone, breaking the bone, destroying the periosteum. Now the Sharpie's fibers are more strong as compared to rest of the periosteum. They survive and they are pulled like this. Any part of the periosteum, when it is pulled away from the bone, it gets mineralized and it forms an appearance called as spiculated periosteal reaction. Even this appearance is possible in Ewing's sarcoma. Imagine the second part here. Listen to me, beta. Listen to me. Look at the screen, beta. Look at the screen. Very, very important, beta. Look at the screen, beta. Look at the screen. अभी सुबह है बेटा, सुबह है ना. देख बेटा, अभी कुछ नहीं हुआ. सुबह है बेटा. जागो. देखो. Imagine a tumor which grows aggressively, destroys the bone, destroys the periosteum, grows both in horizontal and vertical direction. What will happen? Now the Sharpie's fibers will not only be stretched, they will also be stretched apart in a divergent fashion. And this is what is popularly known as the sunray appearance. Sunray appearance is nothing but a divergent periosteal reaction seen along the Sharpie's fibers in osteogenic sarcoma. Everybody understands the concept? समझ आया? Now can you look at it and tell me, Ewing sarcoma and osteosarcoma, which of them, okay, but which of them is more aggressive? Look at the picture and tell me, कौन सा ज़्यादा aggressive? We know osteogenic sarcoma is more aggressive. Why? Because it is not only growing in this direction, it is also going in the horizontal direction. That is why you have sunray appearance. Now, one more image, beta, one more image to understand. Suppose this is the bone, this is the periosteum. Look at the screen, beta. Look at the screen, beta. Look at the bone, this is the periosteum. Just one word to learn, but you will not understand if you don't see it. Beta, dekho. Imagine a tumor which is destroying the bone. Dekho. Destroying the bone, destroying the periosteum also. Then what will you see? You will see a tiny interrupted periosteal reaction called as Codman's triangle. Again seen in malignancies like osteosarcoma, but can also be seen in Ewing's. Are you clear? Okay, everybody understands this or not? What is Codman's triangle? Codman triangle tells you that there is a tumor destroying the bone, destroying the periosteum. Only a part of a little bit interrupted, broken periosteum is seen. That is osteosarcoma, Codman triangle. Okay, Sharpie's fibers are not destroyed because they are more resilient than the normal periosteum. They are more strong, and that is why you might have read about all this in your pathology as well. Now, to summarize what we have seen so far, always look at the age of the X-ray by looking for growth plates. Look at the location of the tumor. Look at the pattern of destruction. Look for any matrix. Look for cortical break. And look for periosteal reaction. These are the basic principles of looking at an X-ray of a suspected bone tumor. Sunburst and sun rays, okay, beta. Okay, so these are the basic principles. Age. Okay. Kinnal, beta, which year are you in, Dr. Kinnal? Which year are you in? Okay, let's see. Okay, now we come back. Let's see. We come back. Okay, Ewing's also will show Codman triangle. Now, once you are able to see this, I will now show you some X-rays to make sure that we really understand the concept. Okay, let's see the first X-ray on a bone X-ray. Now, so far we have only seen the brain and the lungs and the heart. Let's see the bone. Okay, everybody now look at it. Are you with me? Yes. Okay, now see. What is the age group of this X-ray? To understand the age group, we need to see the growth plates. This is the growth plate beta. Growth plate is the gap between the metaphysis and the epiphysis. So if I'm able to see the growth plate, I will simply say that this is an X-ray of an immature skeleton. Skeletally immature. Where is the disease located? Disease is located in the tibia. Where? In the metaphysis. कहाँ है सर बीमारी? बेटा ये देखो. बेटा देखो. This is epiphysis. This is metaphysis. The shaft of the bone is called the diaphysis. Okay. Thank you, everybody. You know, it's Krish's birthday today. Yes. Thank you so much. Okay. Now, everybody, now let's see if you can answer, beta. Oh, बच्चे कोई नहीं. You're not tired. Don't worry. 5 minutes तो करेंगे बेटा. ये नहीं तो समझ नहीं आएगा बेटा. Okay. Anybody, listen to me. So, in an immature skeleton, tibia is involved, and there is a metaphyseal lesion. Beta, see. The tibia, the metaphysis is abnormal from here to here. It's the entire area looks abnormal. The entire area looks abnormal, but tell me, listen to me, tell me, can you draw a border around it? No. It is a permeative pattern of destruction. Now, don't you think the area which is damaged is appearing very dense? The abnormal area in the tibia is very white. Why? Because it is producing osteoid. It is producing osteoid. Any one of you can answer, beta. Okay. Do you think the disease is limited to the bone, or is it coming out of the bone? Metaphysis ke andar hi hai ki bahar bhi aa raha hai. We can see the tumor is actually coming out of the bone on both sides, and it is stretching the Sharpie's fibers and stretching them apart, causing an aggressive appearance called as sun ray appearance. And not only that, if we look at the diaphysis, the normal part of the bone, listen to me, beta, can you see on the normal part of the bone, are you able to appreciate there is some part of the periosteum visible? But then I can only see it in that part. I cannot see it later on. What is this? That is called as the Codman triangle. Now we know word permeative is telling me कि it's a malignant process, aggressive process. Sun ray appearance, Codman triangle again telling me it is an aggressive process. Osteoid banane wala aggressive tumor. So I will call it osteogenic sarcoma. And also remember, osteogenic sarcoma on radiotherapy is found to be radio resistant. Osteosarcoma is a radio resistant tumor. Everybody understands? Now can you see that how we have applied those principles on diagnosing osteosarcoma? Okay, everybody. Happy birthday, Rajeshwari, also. Great. Okay, now see. This is what I was telling you about. If this is your periosteum, in gross anatomy, you might have studied this in gross anatomy first year. I know you were not studying, but remember, what are these? These are Sharpie's fibers. Okay, so these are what are the Shivans, Dudate, everybody, happy birthday, Rajesh. Okay, very good. So these are your Sharpie's fibers. It is the mineralization along the Sharpie's fibers which is responsible for the sun ray appearance. Everybody clear? Okay, now see if you can answer. Anybody can answer this question now. This is a young patient with pain in the leg, more in the night, relieved by aspirin. Okay, history clear? Young patient, pain in the leg. Okay, young patient, pain. Brijesh also, beta, happy birthday. Okay, Tapender. Happy birthday, Jagruti. Happy birthday, very nice. Please send me a cake. Huh? So, young patient, pain in the leg, night, relieved by aspirin. Okay. Tell me now, what do you see? You can see in the cortex of the bone a small lytic area, a well-defined lytic area in the cortex. This lytic area is called as the nidus. Can you see in the cortex there is thickening of the cortex with a small lytic lesion that is called a nidus. This is what is a benign osteoid producing tumors. That is why the cortex is thickened. So we say osteoid osteoma. Clear? So now tell me what is common in between these two, why they are all in the same page. Both of them are osteoid producing tumor. One is a malignant sarcoma, one is a benign osteoid osteoma. Are you clear? So in osteoid osteoma, the tumor is actually that small nidus which is producing osteoid. So that is why the cortex on that side is thickened. So you could actually see some cortical thickening on the X-ray. Everybody clear? Yes, very good. So this is how you differentiate between osteosarcoma and osteoid osteoma. Let's see an answer. Okay. Now the history is child with clinically suspected osteomyelitis comes to you for a X-ray. What do you think? Child with a clinically suspected osteomyelitis comes to you for an X-ray. What do you think? Okay, any idea? एक बच्चा है जिसके डॉक्टर बोल रहे हैं ऑर्थोपेडिक वाले कि ओस्टियोमाइलाइटिस है. ओके, बस बच्चे हो गया एक और दिखाना है तभी पिक्चर क्लियर होगा, है ना. इनकम्प्लीट नहीं जा सकते हम, है ना. इसके बच्चे के ऑर्थोपेडिक डॉक्टर कह रहे हैं कि ओस्टियोमाइलाइटिस है. रेडियोलॉजी में क्या लग रहा है बताइए. नाउ व्हेन आई लुक एट दिस एक्सरे आई कैन सी द बेसिक प्रिंसिपल्स कमिंग इन फ्रंट ऑफ मी. Can you see? Now I can see this alternate lucent and the periosteal shell of bone, like multilamellar onion peel appearance. No, this is not osteomyelitis. This is Ewing sarcoma. Remember Ewing sarcoma? Radiosensitive, radioresistant. Radiosensitive. Remember? Small round cell tumor. Small blue round cell tumor. Okay, so this is Ewing sarcoma. Clear? Okay, very good. Now see, final picture. One more picture and we'll go. Now, the third picture is a adult where there is a problem in the pelvic flat bones. Where is the disease? Where is the disease? This is the disease. So there is some problem in the pubis and the flat bone. Now tell me, is the tumor limited to the bone? एक्यूट ऑस्टियोमाइलिटिस बेटा सिंगल लेयर होगा ना, मल्टीपल कैसे हो सकते हैं? मल्टीपल लेयर दिख रहा है तो इविंग्स है ना, वो बीमारी बढ़ रही है, रुक रही है, बढ़ रही है, रुक रही है. इट इज नॉट अ स्टैटिक डिजीज. Okay, now see, can you see now, is this disease limited to the bone or coming out? It is coming out. It looks aggressive. And the tumor is having like this, dot, 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 flocculence, 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 flocculence. So we have the tumor is aggressive with flocculent pattern visible. So this is a chondroid producing malignant tumor called as chondrosarcoma. Okay, now any one of you can answer now. Do you realize that my goal was to show you 3 sarcomas in the beginning? 3 sarcomas that we have seen today are osteosarcoma, chondrosarcoma, Ewing sarcoma. Did you realize osteosarcoma it was looking very white, very dense because of the osteoid. Chondrosarcoma it has those flocculent dot 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 flocculence, popcorn like mineralization, chondrosarcoma. And chondrosarcoma is more common in the flat bones, more common in the adults. And then we also saw Ewing sarcoma has no matrix, and onion peel appearance is a typical picture which tells me that, okay, this is not osteomyelitis, this is not osteomyelitis. Osteomyelitis should have a single layer of periosteum. Here I can see multiple layers telling me that this disease grows fast, slow, alternate phases. Clear? Everybody understands the concept now? And this was your osteoid. Okay, so this was the purpose of my class so far. Now, when you come back in the next class, we'll understand more. Now is the time to understand the message of the day before we go and celebrate our day. Okay, the message that I want you to have is this. Okay, the message that I want you to have from me today is progress is more important than perfection. Okay, progress is more important than perfection. Try and understand this. Beta, समझना मेरे साथ, जरूरी समझना है. Okay, now it's very important. I want you to spend 2 minutes with me. 2 minutes सुनेंगे मेरे साथ. You know, I have a friend. Okay, I have a friend who was with me in the college. So after college, he said, Sumer, I want to open a hospital like Apollo Hospital. Okay, I said, okay, let's see. He went on to do his MD medicine and did his DM cardiology. And after he finished his DM cardiology, I finished my radiology and I finished my SR-ship. We met in a party in the college. And he said, Sumer, I want to open an Apollo Hospital. He said, give me some ideas. And he said, give me some ideas. How can I go and make a hospital like Apollo Hospital? I told him that please open a clinic. Okay, gradually we will make a hospital like this. And he laughed at me and went off. Okay, now 15 years later, I met him again in a college get together. Again, he asked the same question. He said, Sumer, yaar, I want to open an Apollo hospital. Yaar. Tell me how to do it. I told him that 15 years back, if you had opened a clinic, by now we would have added some beds, we would have added a lab, blood bank, OT. Gradually, we would have reached to a small hospital by now. But the problem is that perfection, this desire to be perfect, sometimes has a reverse paralyzing effect on you. And what happens is, some people, they only keep waiting on the shore and they keep thinking, one day I will become perfect, then I will start swimming. And that day may not come. And that is very important for you to understand, very, very important, that listen to me, that some of you are not giving your tests because you feel one day I will be perfect and then I will give the test. That is wrong. We need to progress. Okay, tiny progress every day, tiny progress every day, every day, every day, every day, every day becomes something big. You agree here or not? So it is not, the success is not a one-time event. It is a gradual process. More you add, so every day you are moving forward towards your success. So progress is more important than perfection. Very important key. Okay, so just keep thinking. Many times I keep meeting medical students who will say and tell me, they will say, sir, when I will read the complete Harrison, then only I will give the PG entrance exam. I say, बेटा पूरा बच्चे के साथ देना है पेपर क्या अभी देना है you understand my point here or not the key is progress it is not in perfection human being में आएगी नहीं key is improving every day okay so don't be afraid of tests don't be afraid of taking your chances give your exams okay don't shy away from giving the exams progress is more important than perfection thank you very much I wish you all the best it was a pleasure to talk to all of you today god bless you beta god bless you see you next class we will talk more about bones